Order. Welcome to this first public evidence session of the Health and Social Care Select Committee's inquiry into social care, the cost of inaction. It's a delight to have our witnesses in front of us today. So we have Simon Bottery, Sir Andrew Dilnot and Kathryn Smith. May I start by simply asking you to, very quickly in that order, introduce yourselves and what you do?
Yeah, good morning. I'm Simon Bottery. I'm the Senior Fellow in Social Care at the King's Fund.
I'm Andrew Dilnot. I was the Chair of the Commission on Funding of Care and Support in 2010-11.
And I'm Kathryn Smith. I'm the Chief Executive at SCIE, the Social Care Institute for Excellence.
Lovely. Well, thank you all. So, Andrew, let's start with you. You'll have seen Louise Casey has been appointed to commission, the government has commissioned another commission into social care. I wonder if you might reflect a little bit on your experience, and not just of chairing the commission you did, but over the years trying to get it implemented. It's been enacted twice in legislation, and then it was finally dropped by the Chancellor at the beginning of this Parliament. I wonder if you might give us some clues. What went wrong? But also, more importantly, how do we get it right this time? I'll start with Andrew, but then I'll ask both Simon and Kathryn to comment after that. Andrew.
Thank you, and it's great to be here, and I'm delighted the committee is covering this question. I think it's probably a record to have a set of proposals that received the royal assent twice and still hasn't happened. That's not a record that anybody would really like to have. I should say that being involved in the Commission and being involved in this work has been enormously enjoyable and interesting. I think this set of questions that is incredibly important to how we run ourselves as a society. And while it's easy to point the finger just at politicians, I actually think we all have to accept blame, and that includes me. You know, I have failed to articulate in a way that has achieved a strong enough consensus to get action. The population as a whole hasn't complained enough to their MPs. The media have not written about this enough, and politicians have not, in the end, had the courage to go forward and do something. One of the things that I reflect on is that this is exceptionally important, has extraordinarily significant impacts on the lives of people who need care, on their families, on the providers of care, on our whole society. But somehow social care is still pretty invisible. And I think one of the things that I'm delighted about with respect to the new Commission is this is another chance to try to raise this set of issues up the agenda so that we all pay attention to it. I think that's one critical feature. And the history of the last 15 years has been a history of ups and downs. So ups in the sense that we've repeatedly appeared to have consensus immediately after the Commission of which I was a part reported. We appeared to have consensus across all three of the main English political parties that something like what we recommended should be introduced. Legislation was passed in 2014. It was to be implemented first in 2017, then in 2016. Then after the 2015 election was postponed. Then again it was to be, so we had a Conservative and Liberal Democrat coalition recommend its adoption. A Conservative government pulled back from it. Then another Conservative government recommend it, take it through Parliament. Again, not in precisely the way I would have wanted, but take it through. And then a Conservative government pulled back from it. Then in the recent election campaign, we had a Labour Party, before it was in power, formally, on the record, commit to going ahead with the implementation in October 2025, and then I think 3 or 4 weeks after the election, abandon it. So we've had every possible constellation of English political party say they're going to do it, and then say they're not going to do it.
Why?
I think the reason why is partly to do with what I've already said, the invisibility. It's somehow, for reasons that I don't quite understand, not enough people make enough noise about it, so it feels like an easy thing to pull back from. I think the second is that while I think there has been a fair degree of consensus about what should be done on the spending side, that we should properly fund the means-tested system, that the minimum requirement for a decent society is that you properly fund the care of those who can't possibly afford to look after themselves. And there's been consensus that we should move to a social insurance type system. There hasn't been consensus or even much discussion about where the money should come from. Yeah. And I think the reason that the last attempt failed was that when it was legislated for, there was to be a health and social care levy, a small part of the revenue for which would pay for the social care reforms. Once that was abolished by the, I can't remember whether it was the government headed by Liz Truss or the government, I think it was the government headed by Liz Truss that abolished the health and social care levy. Once that had happened, it made it easier for the Treasury and Treasury ministers to say we haven't got the money to do it. So I think one of the critical tasks that faces Baroness Casey and her commission will be to try to get through that nexus. And that's always tricky because the Treasury officials and ministers are always very protective of their rights to talk about where money should come from. Yeah. But I think if we're to get this through, whatever this is, then being open about that will be critical. One last thing, let me just emphasise again that I think there are two separate but closely related issues to be faced here. The first is the funding of the existing means-tested system. We have to do that decently. The kind of challenges facing families and local authorities at the moment are simply, I think, unacceptable in a society with the levels of income and wealth that we have today. We're just not doing that well. And we have that's the clear and pressing, immediate, urgent task. But related to that, we have to have a system that works for the population as a whole, and that means reform of funding. And funding is not the only thing that matters in all of this, by any means. There's a whole range of things that both Simon and Kathryn are probably much more expert on than I am. But if we don't get funding right, we're not going to get those right too. So there are two issues, and I think the short-term imperative of funding the means-tested system often gets in the way of producing a decent system that we can all be proud of.
That's very helpful. Thank you. And we've not seen the terms of reference yet of the Commission, so there's hopefully an opportunity to feed in, so thank you. Simon, would you like to comment on advice for Louise Casey?
Yeah, I think the first thing would be about the leadership of the Commission itself. If you look back as far as 1999 and the Sutherland Commission, the Sutherland Commission essentially fell apart because even the members themselves couldn't agree on the basic principles. And particularly, as Andrew said, the key issue was funding. So some members of that committee wanted to introduce free personal care. Other members of that committee felt that was unaffordable. And so there was essentially a sort of guerrilla warfare campaign between the two sides of the committee going on. So I think getting the membership of the committee right, getting clarity of thought right, but as Andrew says, you have to tackle the funding issue. You have to take it head on, because otherwise you end up with a perfectly formed system which everybody could agree, or most people could agree, makes sense and would work, but there simply isn't the funds in place to make it happen.
Thank you. Kathryn?
I think for me the best thing about the announcement about the Commission is it's got people talking about social care, and I think that goes back to one of the points that Andrew made, that people don't talk loudly enough about social care. Actually, throughout our lives, probably 1 in 3 people will be in contact with somebody who needs social care, but people don't know about it until they know about it, and by the time they know about it, it tends to be too late, and it tends to be too late for people to start lobbying their MPs because they're knee-deep in trying to care for people with really difficult needs, or being cared for themselves. So I think getting the conversation on the table is very, very good. However, as colleagues have produced, the King's Fund have produced over the years, an analysis of how many green papers, white papers, commissions and everything else we've had. I've worked in social care throughout all of those green papers, white papers, and every time one comes out you think that you're going to get somewhere, and to be honest it's just Groundhog Day. So what difference is this actually going to make? And in fact, by the time the recommendations of this Commission come out, it's going to be too late for too many people. So I think whilst the Commission really needs to look deeply, working with people that draw upon social care, to look at what the future social care situation could look like, what the reforms could enable. We can't wait for the end of that. There has to be action now, there has to be funding now. And in terms of thinking about where it comes from, I don't have the answer to that, but what I would put forward is when we think about putting the extra money into health, I don't think we're really thinking about the fact that we will not resolve the system in the health service if we don't resolve social care. And I'm not convinced that health colleagues recognise that either. And I think if we could really generate the evidence to show that if we could support people to live well in their communities, they would be less reliant on health services and hospitals. And we've not got that right for a long time.
Yeah, and that's exactly, in a way, what we're trying to get to the nub of with this cost of inaction inquiry, because there could well be savings that could be made elsewhere, and we're very interested in hearing about that. I've got some quick questions, first from Joss Fenton-Glynn and then Andrew Dodd.
Yeah, thank you all for coming, and it's I think quite a good week for you to be here, really, given all the other announcements. I reread the Sir Andrew's report earlier this week, and it did strike me that, as you say, the kind of the thing that's sort of missing from it is where the funding's coming from. I'd be interested, kind of with your hat on as a former chair of the Institute for Fiscal Studies, if you could kind of speculate on where that could be from. I also think that there's another thing, just to Kathryn's point about people not being aware. One thing that I'd forgotten that was in the report when I reread it was the stuff about the how useful it would be to advertise throughout kind of life and actually put funding into making people aware that they have it, because I mean I've as a former social care leader on a council, a lot of people just aren't aware that they have to pay for their care until they do, and I think we've almost missed kind of 10 years of public education on that. And I wonder if you could just talk to that and just what we can do to build that awareness so that people do plan a bit better for their future in terms of that, rather than kind of the assumption that the tab will be picked up. So first to Andrew on if you could speculate on where the money might come from.
Yeah. I think it is an important question, and one thing is to think about the scale. So government spending, total government spending this year, I think the latest OBR public finance database had it at estimated £1,279 billion. We spend a bit less than £30 billion on adult social care, of which about half goes on elderly social care. So about 1% of public spending goes on elderly social care. The reforms that were not implemented not going to be implemented in October 2025 would have cost, in the long run, about £5 billion a year. So these are tiny amounts of money compared to overall levels of public spending, and very small amounts of money compared to the amounts of money that have recently been added, with enormous support, to the health service budget. So the amounts of money involved are not the kind of amounts of money that in general would require an additional special stream of funding.
I would gently suggest that the policing budget is £8 billion, so £5 billion isn't an insignificant amount of money.
It's not insignificant, but it is very small relative to the health budget, and it is small relative to the amount that has just been added to the health budget without a special stream of funding. So I think it would have been perfectly feasible at a number of occasions in the last 15 years to have gone ahead with this without a specific form of funding. My view more generally is that the means-tested system should be funded through general taxation, just as we fund the means-tested system for anything else through general taxation. I think there is an argument that if the government, if the country agrees that it is going to add to people's entitlements, create a new entitlement to social care support, that it's not unreasonable to expect people to pay for that. If the government is doing it because the market fails and can't do it, if the private sector were doing it, we would pay for it. So I think that's not unreasonable. I think the health and social care levy, while not perfect in every way, was quite an interesting idea. And I think one of the things that Baroness Casey will undoubtedly be wanting to look at and think about is whether there's an argument for something like that. It's important to remember that most of the money from the health and social care levy was not to go to social care, it was to go to health. But I do think there's an interesting set of arguments about whether, if as a nation we decide to extend entitlements to social care, to move to something like social insurance for social care, should there be a revenue line with social care's name in it? They're all
So a hypothecated tax.
Or something a bit like a hypothecated tax. I mean, as Josh says, I was for many, many years at the IFS, and hypothecation makes tax economists feel a bit twitchy. But there's something about having the name of a function on a revenue stream that I think protects it and makes it easier to introduce. So I think that set of arguments we need to look at both in a principled and pragmatic way. The point I'm making, though, to go to Mr. Harrington's point about police, is that these amounts of money are not large relative to the overall government budget. And they're really not large relative to the overall government budget. So it should be feasible if we can get enough political consensus to get something done without causing a large perturbation to overall public finances.
Thank you. Simon, has the King's Fund done any work on this, where it might come from?
Yes, and we've also spoken to the public and looked at what the research evidence tells us about what public opinion is on it. Yeah. And there's a remarkable consistency when you look at the evidence about what the public expects. And the public expects that there should be a partnership between the individual and the state, with the individual, where they're able to, taking some responsibility for their costs, particularly in old age. I think it's a different situation entirely for working age adults, but for old age, people accept that where people have the capacity to, they should be responsible for thinking about some of the costs. But they think that the majority of the costs should be pooled, should be borne by the state. And that comes across really consistently in all the evidence I've ever seen. And I've spent, sort of days sitting with members of the public in deliberative events talking about this, and it comes across very, very clearly. In terms of where the money should come from, I think you look at the successful systems around the world, and really there are only two models that people use. In Scandinavian countries, they typically use a general taxation model, and in other parts of Western Europe and other parts of the world, they use a formal social insurance model where a chunk of money comes out of people's salary every month, and it goes into a pot to contribute towards the social care needs of people at that time. The one area that we found extremely contentious when we talked about it in funding terms is people's houses. Yeah. So when you talk about that, there's a very, very strong sense that houses shouldn't be touched. Huh. What I think the Commission could and should look at is whether that means that whether that's simply about saying that housing wealth can't be touched under any circumstances, or whether people would consider some percentage of housing wealth being touched. I think that would be a valid area for it to look at, but it is a deeply controversial issue.
Very helpful, thank you. I've got a few quick-fire questions of the committee. I'll get around as many as I possibly can in the 10 minutes we've got. Andrew George.
I just wanted to work out, Andrew, whether you felt optimistic for Baroness Casey. I mean, from what you're saying in the last decade and so, it's been kind of muddled along. I'm just trying to interpret both your language and body language with regard to how confident you feel. Do you think it would take the media to slavishly regurgitate the ill-informed words of an American billionaire to kind of get the debate moving? I mean, what is needed in order to kind of give you the confidence? I don't think you are confident. You don't exude confidence for Baroness Casey.
I'm never confident in the short term. I'm terribly confident in the medium and long term. I think it's so blindingly, excuse my language, bleeding obvious that something should be done here, that in the end, in an intelligent, affluent, civilised society, we get this done. To be absolutely blunt, I think the critical thing here will be the Prime Minister. Mm-hmm. I think one of the things that makes me feel most optimistic is that my understanding, although as the Chair says we don't yet have the terms of reference, my understanding is that Baroness Casey has said that she needs to report directly to Prime Minister and that will be what goes on. My experience and my hypothesis is that to get something like this done, a Prime Minister has to be committed to it. And that on the two occasions when we've had legislation in the last 15 years, that's where we got to. Lord Cameron became committed to this, and that's how we got the legislation in 2014. Mr Johnson criticised for many things, but in this area, Boris Johnson really did care about doing something about social care, and in the teeth of considerable opposition within his own party, because of that, something happened. So I think Mr. Sir Keir's views will be absolutely critical in this, and if the Prime Minister gets behind this, then something, I think, will happen. So I am optimistic. I'm always vague about timescales, but we will get this done, and we must, because how can we look ourselves in the mirror and not deal with this? I was struck by something that the current Secretary of State said in the House a couple of days ago. He said, talking about the NHS, said, those stories belong in pre-war Britain. Well, the stories that we see about social care belong in pre-war Britain. He carried on, they should shame, he said, the Conservative Party, and they should shame all of us. Then he said, I'm determined to end the two-tier healthcare in this country so that whether you are the richest or poorest person in Britain, you get timely, quality treatment free at the point of use. Well, I can't think of any reason why that statement should apply to somebody who has pancreatic cancer, but not apply to somebody who has dementia or severe arthritis. Yeah. So I think we will get this done because it's so obvious that we should. The precise timing, who knows?
Thank you. Greg Stafford.
Thank you very much. And it's on the timings I just want to quickly ask, because you talked about an urgent need in the short term, and I think, Kathryn, you said this report, this commission will be too late for too many people. What's your feeling on the timescales of this? What is actually going to happen over the next 3 years that will be different from what you did will make the difference? Would you have liked to have seen this commission report earlier?
I'd certainly like to see it report earlier, and I very much hope that it will. I don't get the impression that Louise Casey is somebody who likes to hang about. I can't think of any reason why it should take 3 years. I simply can't. And the commission that I was part of took a year from being commissioned to final reporting. It's absolutely vital to try to bring people along. It'd be very important for Louise Casey to be able to talk to people as she's going on, very important for her to take evidence from as wider people as possible. But 3 years seems to me an inappropriate length of time, and in particular it gets us too close to the next election. Yeah. Something else that I think I have definitely learned is that to make a decision on this, that decision ideally is made in the first half of a parliament, because otherwise events get in the way. So one of the things I really hope is that once Louise Casey starts on this, she'll think, okay, let's get going. Producing a report potentially a year or 6 months before the next election just doesn't seem like the right timing.
Thank you. Ben Coleman.
Thank you. Kathryn, you suggested that you have some concerns about how well the NHS gets it, that it needs to sort out social care in order to achieve its own ambitions. I just wondered if as a former cabinet member for adult social care and health, I share those concerns, and I wonder if you'd like to say a bit more about that.
Yeah, I mean, anecdotally, I've felt it over a long period of time, because over lots of different issues. For example, trying to get joint health and social care records, trying to get the health service on board with that is not easy, especially GPs. But actually recently I sat on a round table that was predominantly health consultants and others, with just me and one other social care person, and they were genuinely fascinated because they were hearing things that they didn't know. An orthopaedic consultant, why would they know about what social care could make a difference, could help to prevent those falls, could help somebody to be eaten well and to be cared for well, manage people's continence needs so they're not running to the toilet and falling over. How would they know that? And I think one of the questions, I think it might have been Josh asked previously, is how do we get this out there? And I think the biggest problem here is that people don't understand what social care can do. It's not care homes. It's not about just older people. It's about all working age adults, as well as older people. And it's about supporting people to live well in community and being able to manage their conditions well. And I was going to make the same point about why on earth would somebody that has pancreatic cancer have everything paid for, free, NHS is free at point of delivery, but somebody with dementia that is also a terminal condition, is a medical condition, doesn't. Why would the public know that? Because it doesn't make sense.
Right. Thank you. Jen Croft.
Thank you. I'd just like to quickly touch on the issue of funding. Simon, you mentioned that you've done work with the public to test out where they think the money should come from to pay for this, and that the individual should pay some costs, but the state should bear the majority. Do you have a feeling as to what the appetite is generally, whether that's sort of media or public or wider, for having an increase in either a levy or an increase in tax or a certain particular type of national insurance? Would people be willing to do that, or is that the huge sticking point to actually sell this as a, well, it's going to have to be paid for by individuals essentially at some point?
Yeah, I mean, I think, again, when you look at the evidence, when the levy that Boris Johnson was due to come in, it was a popular policy when it was announced. It had quite wide public support. And when you ask people, they do say, yes, we're willing to pay in order to see a better social care system. They get it. And when you specifically ask people about social care in their list of priorities of things that they want sorted, they will put social care quite high. They will say, yes, it's high up our agenda. However, when you ask people unprompted what are the things you most want sorted out, then social care typically doesn't come anywhere. So they will talk about immigration, they'll talk about police, they'll talk about the economy, but social care will come in quite low down. So there is a bit of work, to put it mildly, that's needed to be done to get it from being social care, the thing that matters to you when you're thinking about it and when you've got an urgent need for it, or your mum or your dad or your sister has got an urgent need for it, into the thing that you recognise is a fundamental part of the health and care landscape in the country, I think.
Thank you. Becky Cooper.
Thank you, Chair. So, Andrew, if it were yourself that had been asked to do the review again and not Baroness Casey, do you anticipate that you would find anything different in the review this time that you found, that you hadn't found previously, or do you think the landscape is largely unchanged?
I think it's, at a structural level, largely unchanged. I think it's worse. So over the last 15 years, the number of people in the age group of which I'm now nearly a part has increased very much more rapidly than the funding. So we've seen actually a reduction in the number of people who are receiving state-funded support and care, despite the fact that the numbers needing it has grown. So I think the urgency has increased. We see all the problems that I'm sure we'll come on to later. Staff under unbelievable pressure, inadequate numbers of staff, decisions being asked of local authority employees which none of us would like to make, care not being provided to people who need it, an NHS with many more people in hospitals than should be there. So I think it's become more urgent. I think there were essentially two things that we said in our review. The first was you've got to fund the means-tested system properly. I think that's even more urgent now than it was then. I think the gap between what's being provided and what's needed is bigger. The second was we said that we have to find a way of pooling, of pooling risks for the population as a whole, so that people are actually able to plan and provide. I think that's fundamentally there. I do think that a set of issues that we were explicitly not asked to look at, where the money should come from, is essential, and I hope that's something. So that's something that Baroness Casey's review, I think, although we don't yet have the terms of reference, will have in scope, and I think that's something that really requires some work. But no, I think the fundamental position is structurally the same, but actually worse than it was then.
Deirdre Costigan.
Thank you, Chair. And thank you very much for coming to speak to us today. Sir Andrew, we've been talking about the Casey Commission, but of course the government's already set out some steps to transform adult social care. One in particular is bringing in a national agreement around fair pay and consistent pay for social care workers throughout the country, along with a career progression system that will hopefully make those workers feel valued and will lead to better quality social care. Do you think that that's a good first step by the government and the department, and does it give you reasons to feel positive about the department's commitment to taking the next steps that will be required to fully transform social care?
I think it's a good step rather than a bad step, but I think it's inadequate in scale and vision. Something that we have to recognise is that at the moment social care is a private market. It's delivered by the private sector. And there are 1.5 million people, wonderful people, almost without exception, working, providing care in exceptionally difficult circumstances, under enormous strain, but doing it in ways that preserve the dignity of those that they're looking after, but they're not paid enough. And because there are 1.5 million of them, to have them paid appropriately costs a very large amount of money. The amounts of money that have been allocated are simply nothing like what could make a big enough difference there. So I think it's good in the sense that it demonstrates that there is an awareness that this is a challenge, but it's nothing like equal to the scale of the challenge. And the only, there are two big options here. We could nationalise the whole thing. We could move it to something like the NHS. I don't think that's politically on the cards. If we don't nationalise it, then we have to make the market that is there work. And we haven't done anything yet that will really make that work. So these are good steps, and they indicate a desire to do something that will make a difference. And they will make a difference, but they won't make anything like enough difference to make enough difference to give those wonderful people working in this sector a proper career structure, the hope of decent career progression, the hope of adequate pay. We have to do something much more thoroughgoing and on a much greater scale than what's been done so far, I think.
Robertson.
Quickly, just coming back to this idea that perhaps the public don't rank social care as important as other issues, might the problem be that they don't necessarily characterise their concerns as social care? It's a label problem. They are worried about whether they're going to be able to pass on money to their children or keep their house, or long-term frailty in older age, or indeed for their own parents. But they won't respond that is a social care problem, and we accidentally put it into another category like health or like taxation or something. And actually the concern for the social care issues is actually much higher in people's priorities. It's just we mislabel it, or we think that people understand social care in the same way decision makers do.
Yeah, I think that's very fair, actually. I think if you characterise it as care of the elderly, for example, those issues will be relatively high up. And there is a question about the specific language. So when the work was being done about implementing Andrew's reforms, the DHSC looked at using the term care and support, and they found that the public actually understood that, and they understood both that there was a grade that care was more intense than support, and so they started to use care and support as the term that they used. Having said that, having spent the last 10 years trying to get attention to social care and actually feeling that we've probably made had some success in that, I'm not sure that we should be looking at another term. But the basic principle of let's turn this into an issue which is about care of your brother and sister with a disability or your elderly parents, I think that's a more effective way of communicating these issues, certainly.
Thank you. Paulette Hamilton.
Mine is a really quick question. It's going back to Baroness Casey and the review. You've made some really powerful points, but the point I'd like to make is, all right, the review is going to take 3 years maximum. All right, Baroness Casey, I think will speed that along a lot quicker. I also think it's really good that Sakia is also there, that she's going to feed back to him quite quickly. If there are some glaringly obvious things within the review, the three parties are involved, the review is going ahead, there are 2 or 3 points that are glaringly obvious that needs change now. Are we going to be waiting till the 3 years, or are people like the King's Fund, yourself, SCIE, going to be really lobbying government to implement those earlier, even though the review is going on?
I think that goes straight to it. I mean, I think Louise Casey will very quickly work out what needs to be done, and I think she should say what needs to be done very quickly. I think she'll find that the whole sector, everybody who's interested, will be vigorously supportive of getting something done, and in the end, I think it will turn on the Prime Minister.
So you do think it can be done a lot quicker with that pressure?
I think it will be perfectly feasible for the government to expect by the end of this calendar year, I haven't quite got in, by the end of 2025, to say, actually, we know what needs to be done. This is what we're going to do. That's perfectly feasible. We understand the challenges. We understand what the options are. It's really a matter of political courage and political decision making, and we all know that things can be done very quickly. Once a government, a House of Commons decides it wants to get something done, it's possible to get something done very, very rapidly. One of the many lessons we learned through COVID was actually you can respond very quickly. This is a chronic rather than acute problem, but it can be addressed very, very fast.
Which unfortunately the last government didn't actually do. They were very supportive, yes, but it didn't get done. So I do think that's the slight difference that we've got now with the review that's coming ahead. If the sector absolutely get behind Baroness Casey and say we need to see immediate action, in my humble opinion. But I'll hand back to the chair.
Thank you. Danny Beals.
Thanks. I've got one follow-up question from what's been discussed before, and then I'll go into my substantive question. It would seem from the discussion today, and you talked about, I think, the Sutherland Review from 1999, so 25 years of discussion about reform, there still doesn't seem to be consensus about fundamentally the core question of how to fund the changes we need. As you say, we all kind of have a sense of where we should get to broadly, but still after 25 years of commissions and investigations, inquiries, really good work being done, including by yourself, there's still, I haven't heard consensus about a funding model from all three of you. I'm sure if we go around this table, there wouldn't be consensus at this point in time within as well as across political divide. So it is 3 years an unreasonable timescale to try and reach that consensus, bearing in mind it hasn't been reached in 25 years of reforms and investigations.
Well, I'm not sure that it hasn't been reached. It has actually been reached. It's been passed through Parliament twice. And then in the run-up to this election, the party represented by the current government and the person who's now the Secretary of State for Health and Social Care said that he was going to do it. So there has actually been repeated consensus, repeated promises to deliver, just not actually delivering. My own view about this is now a matter of political courage and decision making, and I don't think we need a very long time to work out we just need somebody to decide what they're going to do, and my own view is that 3 years is a completely unnecessary period of time, that if we could simply focus on it, then we could get that decided very, very quickly. If I'm sure Louise Casey needs some months, not least to talk to people, but after a few months, Louise Casey sitting down with Keir Starmer should be enough. And waiting until 3 years and then getting the Prime Minister to concentrate on it 3 years from now, I don't think we need to wait 3 years. I think a period during which Louise Casey is able to acquaint herself with what's going on.
Just come back and challenge that. From what I've heard from you so far, all three of you, I haven't heard a consensus about how a national care service should be funded. I've heard a number of options, but to me, that you in your discussion presented challenges in terms of media and public opinion as well as political division that have arisen. Doesn't seem to have been sustained consensus based on, as you said, the changing political decision-making landscape. And I think I might be wrong, but I'd be keen to hear from Simon's presentation, there seems to be quite deep conflicts in public understanding about intergenerational fairness around use of assets, which directly conflict with the principles of means testing. So I'm keen to be challenged if it is the case. So do you feel there is a consensus publicly, politically, that's very easily come to about how we should fund a significant investment in social care?
I think I'll turn to Simon. But my view is this is a case where we need some political leadership. It comes down to that. And to hide behind waiting until everybody has agreed, in the end, I think getting political agreement to where the money comes from may turn out to be very tricky. It's very hard, and hard to see what the upside for an opposition party is to saying, oh yes, we should take money. So I think this is a question of political leadership. I'm an economist, not a political scientist, but at the moment we have a government with a very, very large majority, and if they have the courage to say they should do something, and it's a sensible thing to do, I think you should get it.
I'm reading that as a no, there isn't a consensus, but you're looking for decision making, and I respect that. I suppose from what my reading situation is, there's been a request for Louise Casey to come up with the groundwork to take those decisions. But I guess moving on, I think one of the things that really struck me from very early in your presentation was you talked about significant costs in the system, but they are invisible fundamentally. So I think that comes to the core of what this inquiry is looking at is the cost of inaction, the invisible costs that are in the system at the moment of not doing and having not acted for 25 plus years. So coming to that specifically to all three of you, I'd be welcome to hear your thoughts about what you feel and see the cost of inaction around social care, whether individually, for society, for the economy, for the NHS?
Well, I'm happy to go on to start with that. So on the train on the way in, I wrote down a list. And I think one of the important things to realise is there are costs that accrue to a wide range of different people. So there are costs that accrue to individuals, to families, to the health service, to providers, to staff, and to local authorities. Let me run through that very quickly. So to individuals, the cost of Inaction starts with the actual financial costs that people face, which can be large and are unknowable. So I've often likened this needing social care to being in a shop with no prices, because you know how much it will cost each week or month for your partner or your mum or your grandma to be looked after, but you've no idea how many weeks or months it will go on for. So you don't know what the cost will be. So there is direct financial costs. There are cross-subsidies. So people who are paying themselves are actually cross-subsidising local authorities, because people who pay themselves are paying a higher rate, in particular for residential care, than local authorities. There's the savings that people build up, particularly those who are not especially wealthy, just in case they need a very large amount of social care. Now, 80% of 65-year-olds will need social care before they die. But the amount that each of them will need is unknowable. And most of them won't actually need very much, but a small number will need an awful lot. But in the current system, all of them are faced by needing to set aside enough money just in case they're one of the unlucky ones. So a significant cost of inaction is that many people, not with especially large amounts of income and wealth, are setting aside money that they won't actually need because there is no pooling of the risk. Then there is the enormous fear and anxiety and distress caused by the current system. That is a huge cost to individuals, as is the lack of care that should be delivered but can't be delivered because we're not funding the system properly. And because of that, we are getting premature loss of function and of life. So individuals are losing the ability to achieve activities of daily living and losing their lives prematurely because of care that is there and shouldn't be. And we have people wishing that they weren't there because they feel they are a burden. And added to that, we have the misery of people who don't need to be in hospital but are. Those are the costs to individuals. The costs to families and friends are all of the above, and being faced by horrible decisions about whether now is the time to spend some money putting in a stair lift or putting in a downstairs loo, or whether they should keep that money just in case grandma needs more care later on. And the impact of informal care on people's ability to work, on people's ability to function. Then the health service, and this will be, I expect, high up your list. There are the direct effects of ill health and harm caused by poor care. So people, as Kathryn said, I'm very keen for us to talk about incontinence. We're rather British, so we tend not to talk about incontinence. Kathryn, to her great credit, talked about incontinence. I talk about incontinence a lot. If you're an elderly person with significant social care needs, you're very likely to have some continence challenges. That's quite likely to lead, if you haven't got a downstairs loo and you've got to get upstairs to get to the bathroom, to your falling down the stairs and ending up in hospital with a broken hip or a broken leg unnecessarily, and the direct burden of that on the NHS. And then, of course, there's the indirect effect on the NHS, that because there isn't good social care that we can get people into when they need to leave the NHS, we have NHS hospitals with many people in them who shouldn't be there, who don't need to be there. It's more expensive for them to be there, and it's much less good for them. The frustration that causes to clinicians is extraordinary. Then we need to think about providers. The lack of a functioning market means that there are very low returns to innovation and investments. There's not much innovation and investment going on. They are squeezed. We have endless stories of providers handing their contracts back to the local authorities because they simply can't make things work. And this large sector, which could be a source of growth, the government is committed to growth, this could be an area where we could see economic growth if we had a sensible model. We don't, and so we can't. Then staff. Well, staff are under intense pressure, really intense pressure, and are not paid enough and have very few opportunities for career progression. All of that is a function of the structure that we have. And then local authorities, the last group I want to talk about, the inadequate funding of social care means that all other services that local authorities provide are being squeezed, and the decisions that local authority staff are asked to make would try the wisdom of Solomon. If any of you want to experience a really, really stressful period, go and sit alongside somebody who is making decisions in a local authority about how to allocate the inadequate resources to people who desperately need care. So all of that long litany, and I'm sure there are many others that Simon and Kathryn could add, are either direct or indirect costs of inaction. And while fundamentally I believe that we should act in this space because it's wrong not to, it's now the case, even more than it was 15 years ago, that not doing is having massive instrumental costs on both individuals and the NHS, and that's another really powerful set of arguments for action. Sorry to go on at such length.
I don't know, Simon or Kathryn.
Can I come in? Andrew's covered a lot of the points that I was going to make, but I'd just like to embellish some of them a little bit and also talk about some of the different options I've seen. So if we go back to the impact on the NHS, and I'll pick on incontinence as we don't talk about it enough, I'll talk about it some more. The risk of somebody needing more support. So for example, you've got somebody that's incontinent. At the moment, social care is not supporting them properly. In fact, quite often, I'm going to say she, might be forced to stay in bed with incontinence pads, that she might get changed 4 times a day if she's one of the really lucky ones that gets home care 4 times a day, and she'll be left to sleep in her own pee or whatever else overnight. That leaves that person, first of all, at risk of pressure sores and other things. They can be really serious and lead them to going into hospital. It also risks their own mental health and well-being, depression. That can cause other issues. As we've already talked about, the risk of them trying to manage themselves and getting out of bed, falling over, whatever, trying to get to the hospital. There are so many other issues that we could give examples of where the impact is to the health service. I'm going to give you, this is a real life example, but this real life example could be multiplied 1 million times. So somebody that I have worked with recently, mother has quite advanced dementia, son is disabled, not able to get care and support. I think they've probably been waiting for an assessment for more than a year now. Mother has had to give up work to look after both of them. She's now looking at what benefits she might be able to claim. She's extremely lonely and fed up. She's dealing with quite a difficult life, really, and that is making her more and more susceptible to depression, to other things that will in fact impact on her own health, which means she'll draw on the care service. In the meantime, her disabled son hasn't been able to get to work because of other parts of the system not working together. And I'm bringing this example in to try and highlight how actually reforming social care and reforming social care well, whilst it might not be explicitly one of the government's current missions at the moment, actually would support some of the other missions, like the economy, like the workforce, like getting people to, housing, etc., etc. So this young man can't get to work because the other parts of the system are not working well to support him. So he's having to work from home. He's getting isolated and lonely, likely to end up with mental health issues and other social care issues. In the meantime, mom is falling, daughter's struggling to look after her. Mum fell just two nights ago, cracked her head, ended up in hospital. Nobody's sleeping. This situation is 1 million times over across the country. It's a really, really difficult situation. Then when you start to go and look at good quality care, and recently over the last year or so, at SCIE we've been focusing on innovation and good quality care, and I think that that's something that really needs to be considered.
You're going to come back to that.
Yeah, and then you can see the difference that can have on people's lives, but unfortunately, it's not paid for. And even when people do find some money to pay for innovation, they can't keep it up.
Thank you.
Thank you, Chair. Just to follow on from that point, and we're thinking of this idea where over the last, 20 years, we've had the Treasury, I guess, come back on every iteration of your reports, Sir Andrew, and other options put forward with the answer that, it costs too much. And so do you think that the Treasury fully understands the overall cost of not taking action, and some of the issues that Kathryn's outlined, so that, you know, people are sat in expensive hospital beds because there isn't a social care system that will allow them to go back and live independently. People are getting sicker at home as they wait to get into those beds, or they're falling down the stairs, Sir Andrew, as you said, because they've got no downstairs bathroom. People are having to give up jobs to look after elderly parents, or they're becoming mentally ill because of the pressures of doing that, as you've outlined, Kathryn. So in the discussions you've had with government and with Treasury in particular, do you have any reflections on how well or not the cost of that, the overall cost of doing nothing, is actually assessed by Treasury?
My impression is, I don't wish to appear to be unduly critical of people working in the Treasury are doing a very difficult job, and they're people of extremely high ability and commitment to the public service. I do think there can be a tendency to think about these in a rather static way. So to look at the costs of reform and the costs of funding the means testing system properly and see that without thinking about the benefits that flow both to individuals' well-being and possibly also to the wider economy and to the costs of things like the NHS. So I think there can be a tendency to have too static a view, to have too accounting a view of it, simply to work out what the costs of action will be and not to think about attempting an assessment of the benefits of that action. And while on the whole I think that we should be doing this because of the benefits in terms of human flourishing, I think that's really why we should do it. That's why we founded the welfare state after the Beveridge Review in the 1940s. That's really why government should act. Nonetheless, I think it is now the case that the instrumental costs of inaction have reached a point where they quite possibly dwarf the costs of doing it properly, and I think it's important. And one of the things I think this review...
Do you think the money could be recouped? Is your instinct?
So my instinct is that in the short run there can be significant benefits, in particular to the NHS. I don't think that means NHS spending would fall, because I think it would mean that rather than NHS spending money, for example, on having people in hospital beds who shouldn't be there, they would then spend the money on having the people in the hospital beds who needed elective care. So I don't think we would... and I also think, honestly, that in the long run, it's likely that if we did social care better, the costs of social care and of the NHS would rise. And that's because if we did social care better, people would live longer. And I think the sense is that the longer people live, the more likely it is that they'll have a period of high dependency at the very end of their lives. So in the end, I think we have to face up to the fact that the reason we should do social care well is the same reason we should do the NHS well. We don't have an NHS to make the economy run well. We have an NHS so that people can lead flourishing lives. That's why we should do social care well. However, the lack of doing social care well in the last 15 years means that now it's the case that we are creating enormous pressures on the NHS, and I think in the short to medium run, if we did social care better, we would release funds within the NHS to do what we want the NHS to do much more effectively. I don't think that we will, certainly in the long run, reduce costs by doing social care well. But that's not really why we should do social care. And I do think that in the short to medium run, we're doing it so badly that it is having massive knock-on costs to the NHS, but also to the wider economy. And I think that the place to think most optimistically about the possible recouping is that actually if we did social care well, the example Kathryn's just given is an example, more people could work, the supply of labour could be a bit higher. If we did social care better, had a proper market, then we would see much more innovation and investment in the sector itself. We could create a dynamic sector. We could become world leaders in social care. So I think there are potential benefits, and any benefit here will look pretty large relative to the costs of reform. The national economy will be between £2.5 and £3 trillion soon. Making social care, which is a very large number of people, work better could be a dynamic feature in the economy.
And how do you think then we can make that argument with Treasury? How do we bring Treasury to a position where they understand that the wider costs of doing nothing include, the amount of money we pay out in welfare benefits, for example?
I think there are some, I don't know, for example, the King's Fund may be planning to do some work on this. I know the Health Foundation is also thinking of things. So I think looking at what the costs being imposed on the NHS now are, I think is a really interesting thing to do. And as I say, I don't think if we reduce those costs, we'd reduce NHS spending, but we would increase NHS output quite significantly. So I think that will be a powerful thing. I think talking much more about the impact of the failure of the market as it stands on the economy as a whole is something that hasn't been much done with the Treasury. That's a discussion I've begun to have with the Treasury. I think talking about that some more is really valuable. And to go back to the point I made earlier, this state of the world where needing social care is like being in a shop with no prices means that unless you're unbelievably wealthy, you're going to be very unwilling to spend money that you don't have to spend immediately because you're so worried about what the long run could be. If we once have risk pooling, then we have a chance of releasing the expenditure of a much larger group of the population into social care, and that has a chance of creating a labour market where people can be better paid, creating a market where there's a market for innovation investment, and turning the social care sector into an engine of growth. We already see, for a small number of really very affluent people, some quite exciting innovations in social care. The Richard Osman novels, which many of you will have come. So if you're wealthy enough to be able to take the opportunity, but that's a tiny proportion of society. If we can create a system where a much larger group of society can take control of their own care and take their own decisions, then we have a chance of creating something dynamic and exciting.
Although I think a disproportionate number of murders happen in the home in the Richard Osman novels. So just then, to continue on really in that vein, and maybe it's a question also, it'd be useful to hear also from Kathryn, who kind of opened the discussion on this, but also maybe a question for Simon as well. The Treasury at the moment uses the Green Book approach to assessing change and new policies, and I think it is quite focused on the kind of immediate costs and the immediate benefits of changes. So is there how can we actually change Treasury's approach to that so that they account better for those kind of the long-term impact? There should be, there may be ways to monetize that. How can we put a figure on it, put a number on it? Is there a way that we can push the dial with Treasury on that?
I think there's an opportunity emerging, from the development of what's called client-level data. So this is tracking individuals through the social care system and then being able to track them into the healthcare system. And once that's fully up and running, it provides the opportunity to see actually what happens to people who are receiving care services. What use do they make of their GP services? What use do they make of their A&E services? And you can start to see, I think, potentially how social care impacts the NHS in potentially and potentially you can monetize that if you choose to. At the moment, there's limited data on it. There is some data, for example, that shows that where you cut spending on social care, there's an increase in A&E usage. So that there is evidence that can show a direct correlation between a reduction in social care and extra use of the NHS. But it's limited, and I have to say, like Andrew, my suspicion is that there isn't a single sort of smoking gun, a piece of evidence, a piece of research that we're going to be able to say, aha, this shows that by spending £1 on social care, you're saving £2 or £3 in the NHS. My suspicion is that you're not going to see that. What you're going to see is the accumulation of lots of effects across lots of other public services, and that will be the NHS, but it will also be in housing. It will be in the police service. It will be in the benefits system. A wide range of benefits from social care spending, rather than sort of one sort of single bit of evidence that proves value. And you do also, I think, just have to go back to the point that both Andrew and Kathryn made, that ultimately the question is, yes, we need to understand what the impact is, and we need to understand what the value of social care is in a monetary sense. But ultimately, we do it, I think, really for that moral question of that we should be ensuring that the most vulnerable people, and I know there's people don't like the term vulnerable, but I'm going to use it here, that the most vulnerable, the people who most need support, actually are entitled to a decent level of support that allows them to live their lives in the way that they choose to live their lives with a degree of dignity. And I wouldn't want us to get away from that sort of really moral dimension, because I think if you look purely for the economic cost, you're always going to struggle.
Thank you. I'm going to move on to Greg Stafford, and then there's important questions for Kathryn that are coming, so we want to get to this. Greg Stafford.
Thank you very much. I just want to sort of really carry on from that discussion. I mean, I accept that there is no sort of single piece of evidence that is going to change the way the Treasury or anyone else thinks about this. But obviously, we do need that evidence base and that data. So how robust is the data that is out there, and where are the significant gaps that could be investigated either by the Casey Commission or by independent groups like yourselves, that would start to, if not change the mind in a wholesale way, plug those gaps to move the argument forward?
I think you almost need to start from the second part of that question, which is where are the gaps rather than where's the evidence, because at a very simple level, we have very little evidence about the outcomes of adult social care, about the impact that it has on individuals in a usable way. We know a lot of anecdotal evidence, and we can come up with lots of stories and anecdotes about the huge difference that a particular bit of social care, a bit of support, will make to someone's life. But actually, when you then look at what's the outcome in terms of the effect on their employment, their health, we really lack that sort of basic data. And local authorities at one time tried to move towards what they called outcomes-based commissioning, the idea that you would actually commission your service on the basis of what it was achieving for an individual rather than a chunk of service, like an amount of time spent. And largely they failed to do that because they found it extremely difficult to measure those outcomes. So at a really basic level, you need to start there in terms of building up that evidence base about, well, what difference does that social care make to that individual's life across a whole range of areas. And then I think there are very large swathes of social care where we've got very little evidence. I've given a couple of examples of where there is evidence of an impact on the NHS, but I think it's reasonable to ask questions about what's the where people aren't getting, because when you think about it, if someone isn't getting the support they need, then and they're not entitled to it from the state, then there's really only three things that they can do. They can either pay for it themselves, and you can then see the sorts of things that people do end up spending, in some cases hundreds of thousands of pounds on their care. They can rely on their family and friends, and some of the most humbling stories I hear are from people who provide huge amounts of care to often their life partner. If you speak to someone who is looking after their wife who has dementia and is providing 60, 70, 80 hours of care a week, is looking after them during the day, but also quite often looking after them during the night. The massive impact that has on that person's life, and if they're not getting the support they need, that's exactly what they're doing. And there's good evidence about the impact of large amounts of caring on people's mental health and their physical health, but again that could be better. And then if they're not paying for themselves, if they're not relying on their family and friends, then they're going without. And then what happens to them? Well, there's the huge impact that has on their individual well-being, but then there is also that knock-on effect across the rest of the system in terms of the use they make of the NHS, the use they make of the benefits system. So really you need to start from what do we need to know, and actually filling in the gaps. There are an awful lot of gaps to be filled in, I think, realistically.
Yes, I mean, I'll come to Sir Andrew and Kathryn as well on that point. I suppose I accept what you're saying, and it's interesting to hear that. I wonder also if you could both add, how robust is some of the stuff that we are already measuring? So things like waiting times, demand for services, the stuff that we are actually measuring either through the NHS or through social care, and how robust that data is as well.
So I agree with Simon. I mean, the data in social care is weak. It's striking how weak it is compared to the NHS, but that's for a structural reason, that most social care is provided by one of tens of thousands of private sector providers. So we just don't have a nationalised, centralised way of collecting the data. So I think in this space, the data that we probably can rely on most strongly is, for example, we don't call it delayed transfers of care anymore, but the NHS does have reasonable records of the number of people who are in hospital beds who ideally would not be. And I think in terms of a hierarchy of the kind of data that this committee could put together and use in discussions with government, that's relatively easy to get hold of, relatively robust, and is now a large number. What we're, in terms of the NHS, what is harder to get to, but also important as well, how many people are coming into the NHS to be cared for because they've had inadequate social care. You know, how many of the hip fractures, pelvis fractures amongst often elderly women are simply unnecessary. But looking at the aggregate data and then saying, well, doing some rules of thumb, I think that could help us. It's very hard to get hold of data about who's not getting care, who should be, because they're not even getting into the system because the waits for assessments are so long. But I think looking at what average waits for assessment are, looking at what the stock of people who are waiting for assessments, which will be an underestimate of the people who really are waiting, because many people are discouraged from even getting into the system. So I think there's a sort of hierarchy of data that we could build up. It's not as good as it should be, and in particular amongst users of, we don't have the best data that we could have amongst users of social care, and what we really, really don't have good data for is people who are not using social care because it's not accessible to them, and they're probably the most important. But even there, I think, King's Fund, Health Foundation, there are ways of doing SCIE, there are ways of getting estimates of these. They will be estimates with uncertainty, but they'll give us some sense of the scale.
Okay, thank you. Ben Coleman.
Yes, thank you. I'd like to throw something in, which we're talking a lot about evidence, and we're talking about the cost of care, and Andrew, your report talks about the problems of having different funding streams for health, which is free, and social care, which isn't. And Simon, you've said there isn't the money to make it free, and Kathryn, you've said we need to look at the savings to the NHS, among other things, and I'm paraphrasing all. I just thought it might be worth talking about one thing, getting your views on this. In my constituency of Chelsea and Fulham, Hammersmith and Fulham Council, which I used to be the deputy leader of until the election, offers care at home for free, for everyone, irrespective of their income or their assets, just as healthcare is free for everybody. They do this because they think that charging for care is a tax on disability as much as on old age. And there isn't a means test, and they don't have a restrictive eligibility criteria assessment. And so the residents there get the care that they need. You talked about people not getting care and having falls and so on, not just what they can afford. And the council's experience is that keeps people living independently at home for longer. And as a result, I'm told that the number of people entering local care homes has fallen significantly. The council also believes it saves the NHS money in admissions and readmissions, but we'd need academic work done on that. So to come to this issue of evidence, we have this one example. It's the only place in England where this happens. The only place in England where care is free to everybody at home. Are you aware of any evidence that reducing care costs to individuals reduces demand and reduces costs elsewhere in the system?
I don't know if I would be aware of evidence, statistically significant evidence, but anecdotally I think that's absolutely right, and the things that we've seen, because people, by the time people have to pay for their own care, they're not rich. You don't need to have much savings to have to pay for your own care. And people are frightened of doing that because they don't know how long they're going to be paying for and where it's going to go. And I've seen examples where people have not, for example, sought the care they needed for their mother because they would have to pay for it and they couldn't afford it. So they manage out, and mother then ends up worse in hospital, etc., etc. So I think I've spoken to you about this example before. I'd love to go out and see it. I think that is a really good example of a sort of preventative measure to keep people living better at home for longer. And in fact, having previous life worked in a local authority, sitting looking at the means tests, okay, when we have an appeal and that you've got a room full of probably 8 senior council workers, considering whether somebody's spending too much on donuts or cigarettes to be allowed to have that for free, I'm telling you that costs more than having just given that person that extra bit of money in the first place. So I think there is evidence that if we funded the preventative measures better, we would reduce the impact on the more expensive things. But going back to Gregory's question about the evidence, if I was going to be funding a commission, this is what I'd be funding. I think we need to find this evidence. I've seen it. The problem is I've seen this evidence from providers who have done their own research into how their innovative services save money, but it's the provider's own evidence. People are going to say that's biased. There needs to be some independent evidence developed. The evidence that we've got from social care is things like the ADAS survey that has told us that as of March there were over 418,000 people waiting for an assessment or for care off the direct care payments to start. We've got evidence from organisations like Skills for Care that tell us about the vacancy rates at 8.3% higher than that of the general economy because of the funding, etc., etc. But we don't have an overall independent evidence set that shows us at the true cost of inaction on social care and what the potential savings could be if we manage that differently. But I do agree with what both Simon and Andrew have said. Actually, we're here to make people's lives better, and the NHS doesn't exist to save money. The police doesn't exist to save money. They exist to make people's lives better, as does the teaching and every other public service. Why don't we think like that for social care?
Can I just, on Ben's point about Hammersmith and Fulham, I think Hammersmith and Fulham is a really interesting example, and I think it would be really useful to actually look at the experience in Hammersmith and Fulham. Not least because what Hammersmith and Fulham doing is actually what Scotland did in essence. So there was a natural experiment in a way in 2000 or so. Scotland introduced free personal care. It's a very popular policy in Scotland. When you look at it, what they haven't done is actually, and they introduced it because they thought that encouraging using free personal care would encourage people to stay at home longer, which is what people want, to be independent at home as long as possible, and to reduce the use of residential care. What they've never done is to actually explore to what extent that actually happened. And when you ask them why not, they said, well, essentially, we like our policy. Why should we do this work just so for the benefit of England? Yeah. But I think looking at what's happened in Hammersmith and Fulham, where my understanding is, for example, that one of the effects is that people who are receiving care are receiving more care, sort of more hours than they had previously. Looking at that, looking at what impact it has on take-up, how many more people are receiving care because there isn't a means test, and then trying to explore what's the impact on those individuals. I think that would be a really valuable thing to do.
I have to say, if I may, and I have Andrew's view as well, you're making an extremely strong point. I think the Council doesn't have the resources to undertake the depth of academic study and rigorous study that would be needed to identify the answers to the questions you've raised, and it would be helpful if that sort of resource were made available, because it's doing this sort of unique experiment. Huh?
You've made the public.
Well, it's doing a unique experiment, and I think it started for the same reason in Scotland, because it was the right thing to do. And looking back, it probably would have made sense for some sort of measurement to be built in back in 2015 when it began. But we are where we are. I don't know, Andrew, if you want to comment anything you've heard there.
No, I haven't looked at what's happened in Hammersmith and Fulham. I've looked a bit at what's happened in Scotland, and as Simon said, it's popular, but it's left the acute problem of people with very high needs exactly exactly where it was. And so we still have a situation in Scotland where the social care system in Scotland is facing enormous pressure, and people with very high needs find themselves on their own. So I think it would be, as others said, it'd be really interesting to have a study of both Scotland and of Hammersmith and Fulham to see what the effects are. But I think it's very striking that where we make social care more accessible, we make people's lives better. And that's, again, that's pretty blindingly obvious, but it's an important thing to follow up on.
Thank you.
Robertson.
Thank you. I was going to ask a question about how we evidence that spending money on social care leads to at least some savings in the NHS. But I think, Sir Andrew, you made a comment earlier that I think perhaps runs against what I thought was a settled consensus here. So I might invite you to clarify this idea that more investment in social care will ultimately lead to more spending needed in the NHS because people will live longer. But is it not the case that provided people live longer, healthier, you should be able to deliver ultimately savings, or at least per capita savings in the NHS? That, I think, is the view of the Chief Medical Officer in his annual report 2 years ago. It's about living longer and, when life comes to an end, dying quicker and not being left using services unnecessarily. Could I just invite a clarification or view on that?
I think we don't know the answer to this, but what we do know is that the older people are when they die, the more likely it is that they'll have a period of significant dependency towards the end of it. And so now that may be dealt with in the NHS, or it may be dealt with by social care. I think specifically in terms of social care, I think if we do social care better, people will live longer, better, more flourishing lives. That's why we want to do it. The probability is that we'll end up with higher social care costs towards the end of people's lives. And social care costs vary with the degree of dependency and increase with dependency. So I wouldn't want to make a long-run argument that doing social care better will mean that we'll, in the long run, spend less. We'll spend less earlier in people's lives, and we'll give people better and more flourishing lives. But I think it's quite conceivable that we will end up spending, with the economy as a whole, spending more on social care, because if we have the wholly desirable outcome of people living longer, then it's more like then we're likely to have a bit more dependency. And it's also worth saying, I don't want this in any way to sound like counsel of despair. We'll also go on paying people's pensions for longer, which is and that's wholly desirable. One of the great triumphs of the last 150 years across the world is we live longer. And to hear people talking about the burden of ageing makes me fume with anger. It's not a burden, it's fantastic. It's wonderful. The alternative is being dead. So it's great that we live longer. Living longer means that we go on consuming for longer. Some of that money will come from us directly, some of it will come from the state. That's to be welcome. So I wouldn't want to make an argument that by doing social care better, in the long run, we will save money. But now, in the short to medium run, I think we definitely will, because we're doing social care so badly that we're jamming up the NHS in a wholly unhelpful way.
Isn't the point that sort of the capacity for maximum human life hasn't increased? People have always been able to live to 90 to 100. It's just a few hundred years ago, so few people did. And that provided we can get people there healthy or healthier, they tend to die quicker, which, when your time comes, is obviously better than taking a long time to die. I think that was the point, and I accept there are some unknowables in that, but I did want to sort of slightly challenge this notion that by spending more on social care, you inevitably somehow spend more.
I don't think it's inevitable, but I think it's likely.
Okay, thank you.
It's not just social care and NHS spending, it's also pension spending.
Yes,
could I come to Kathryn on a different question? Have you seen, and anyone else, but I think probably best directed to Kathryn, Have you seen any innovations in social care? So now looking beyond the funding issue, innovations across the country that, if the funding was in place, would scale and roll out very well to a more system-wide approach to the whole of the country?
Yes, I've been looking at innovations quite a lot over the last couple of years, and specifically at the moment, SCIE is supporting the government's Accelerating Reform Fund, which is supporting local areas to innovate in their areas. That's fairly early on, but we're seeing lots of innovations in things like shared lives and digital technology and things like that. But some of the ones I've specifically been out to see, a couple of them are based on digital. I'll give those examples. One is using a digital app called Pain Check, and it uses artificial intelligence to scan a person's face, and this is specifically for people that have a cognitive impairment and can't communicate how they're feeling, so if they're in pain. This will tell the carer if this person's in pain, will give them the right set of questions to ask to find out what kind of pain and what support they need. This app has been combined with a different care model, so it's not been used on its own, it's been used with a different care model that has a higher level of training. The staff are paid more, there are higher numbers of staff, and this is specifically targeted in this instance that I went out to see at people with dementia. What they found, and I went out to see this service, is that these people are no longer on drugs like neuroleptic drugs. They're not on drugs that are managing their challenging behaviour, because they don't have challenging behaviour anymore, because the pain is being managed well and their behavioural symptoms are being managed well. They're being well cared for. So they've found a reduction in costs to medication. They've found a reduction in costs to coming in and out of hospital, because these people are no longer going in and out of hospital. And ultimately, and the most importantly, and you can see this vividly when you look at this service, people have got a better quality of life. Now, one of the things, and this goes back to one of the things Simon was saying earlier, it's not quality, it's not quantitative. You can't do a statistical study on people's quality of life. I was working in local authorities when we were trying to do outcome-based commissioning, and my local authority had to stop it because we couldn't quantify it. How do you quantify that somebody's got a better of life? You can see it, I couldn't prove it to our council, and that's really quite difficult. But in this one, there were some, and this is one of the services that's done their own research to demonstrate this, and they have got councils funding this amazingly. But one of the sticking points is that they've got councils funding it because the councils are responsible for the social care, but the savings are to the NHS. Mm-hmm. And that's one of their sticking points in trying to roll that out. Another example I went to see in Oxfordshire not so long ago was essentially a care home. But it was the best standard care home I've ever seen, and believe me, I've seen a lot of care homes. And the people that live there pay an absolute minimum of £2,500 a week, which sounds a lot of money, but it's not as much as being in hospital. And the majority of people that are in that care home are people that have gone there because nobody else can care for them, so they were otherwise in hospital. And it's fantastic. I walked around this care home, I saw the activities they were doing. You're not seeing any people wandering about, you're not seeing anybody sat watching Bob the Builder in the lounge because there's not enough care staff to turn the TV over. You're not seeing people sat doing jigsaws, but children's jigsaws. Everybody is meaningfully occupied and happy, and they've got statistics themselves to show that these people have not been into hospital, etc., as they would have done before.
What's the name of this care home?
Nightingale, it's called, yeah. But some of the people that live there are costing £7,500 a week. Now, when I've repeated this example to civil servants recently, I've been met with quite a lot of shock. £7,500 a week, how can they pay that? And I specifically checked, 75% of the people living in this care home are council funded. The council are paying that because they can't get care for these people anywhere else. And having them there has stabilised them, has given them a good quality of life. And there's other examples of that around the country. Now, I'm not suggesting giving every care home £7,500 a week, because that's not going to turn the culture of care around. But the models of care that are employed in these places, the training and the number of staff that they've got, the staff to resident ratio is so much higher, so that people can be managed well, have their needs met well, and be supported to live independently. These examples are just talking about the care home examples. I've also seen examples out in the community. I'll give you another digital example here, where I just can't remember what this one was called now, it's gone out of my head, but this was a medication that had again artificial intelligence built in, technology built in. So quite often people that are living in the community and are supported to live in the community, and they don't necessarily need to have a cognitive impairment for this, but they just forget to take the medication. And that means that they're not keeping on top of whatever their condition is, and they get worse and other things happen. So this technology is quite simply the tray. I don't know if any of you have come across the trays that people have for the medication, has technology built in. So if the medication's not taken at the right time, the person who's supposed to be taking it is given an alert. If it's still not taken, a carer is given an alert to contact them. And what they've found in this particular one, and again they're doing their own research on this, is that this kind of technology has supported people to make sure they take the medication at the right time when they should take it. What's actually happened with that is that they then don't need that medication anymore because they've got on top of their symptoms. They're able to live better. They might need different medication, they might have other things come across, but ultimately it's really helped them. Again, local authorities are paying for that. The medication is an NHS issue.
Josh Fenton.
Thank you. So to what extent do you think the failure to reform is driving inequalities in both kind of access and quality of social care, and do you think there are ideas for reform that could address that?
Yeah, I'm happy to jump in. There's the huge impact on the inequalities in access to care, and that's worsening. So marginalised groups and people in deprived areas are disproportionately affected. So people are being left without the right support and care that they need. Andrew spoke previously about the kind of hugely wealthy can kind of pay for whatever care they like, and if it's available they can do that and they can get some great models of care. People that have got absolutely no money and no means to access anything, they can get the means tested support and care, but actually that level is really low, and that's changed hugely. When I first started out in social care, we supported people more than we do now. Some of the things have moved on positively, like personalisation and things like that, but actually we support less people proportionally than we used to, in that sense. But then there are people that just quite simply either can't afford to get the right care, don't have the means to know how to even find out what the right care would be. We've got stories of people that our situation has worsened, they've ended up stuck in the house, they've ended up in a really difficult position. People have died from not getting the right support and care they need, people have ended up in hospital, and predominantly the people that have been hit the hardest are people from that sort of marginalised groups and the more poorer people.
I think that's probably true. I was interested, there was a National Audit Office report in 2023, I'm trying really hard not to say last year, which kind of outlined some of the kind of state of social care issues, and one of the things it said was kind of significant authority to authority differences, and you know, part of that is going to be driven by the finances of those authorities, and not wishing to diminish Hammersmith and Fulham, I suspect their council tax base is somewhat greater than some other authorities. I wonder if that's something that you've seen reflected in terms of kind of, you know, when we're looking at a national care services, is how local authorities are working at the moment. Is there a kind of inequality issue because of how local authorities
that
are
is
funding?
huge. And interestingly, SCIE runs sessions with local authority social services directors quite regularly to hear about what their issues are. And one of those directors is currently the director in Bradford, previously was the director in Hertfordshire. And he tells us that some of the issues that people commented on in Hertfordshire were things like transport not turning up on time or whatever. The people in Bradford are just lucky to even get a service. And obviously I'm not going to put words into his mouth, but the disparity in what is available, and actually my experience in local authorities has all been northern local authorities, and there is definitely a north-south divide there, and what the local authority can afford to pay for gives you a different level of quality and care, just even for the means tested people, than what you might get somewhere else. The service I went to see in Oxford wouldn't exist in Bradford.
Yeah.
No, I know West Yorkshire Care quite well because I used to sit on the West Yorkshire CB, so I know that. Yeah, that's. I mean, so I guess So we have that regional disparity. We also have some marginalised groups disparity. And then I guess there's also that ability to advocate for oneself, and do you have family to advocate for you? And you know, I've recently had involvement with the care system, and I used to run a care service, and I still find it difficult. But I think, do you recognise that that's something that people have a problem in terms of the broader inequalities in care?
Yeah, definitely. And being able to advocate yourself or having somebody to advocate for you is a huge issue. And I think this is one of, if you look at the costs of social care across the ages, this is my own personal soapbox, but if you look, the packages of care for a child compared to an adult with learning disabilities compared to an older person, they could all have exactly the same presenting need, but the cost, the availability of care is smaller the older you get. Now, don't get me wrong, it's not good enough for working age adults either, but it's even worse for older people. And I think that that's a lot to do with parent power and advocacy. And who's kind of shouting the loudest, and those people that haven't got somebody to advocate for them. And if you are in need of care yourself, you're not in a great position to advocate. You're already using Simon's earlier words. You're already feeling quite vulnerable and quite difficult. You don't know what's out there. You're just trying to make each day go. And if the person that's caring for you is also struggling with that, then they're going to struggle to advocate. And then if you don't have any family carers in the first place, then the chances are you could be sat in your flat in squalor for a long time before even anybody notices that there's a problem.
And do you think kind of moving kind of more universities, rolling out kind of more strengths and assets-based care systems would lead to better outcomes kind of in terms of healthcare, in terms of people being able to live healthier longer?
Yeah, I mean, if it was funded properly, absolutely. Yeah. And I think one of the issues that I've seen, going back to your earlier question about innovation, and this is really quite sad, I've been out to see services where they're trialling a new innovation and they've got some really good successes, and the day I went to visit it, it was closed down because they didn't have enough funding to do it. And I think one of the issues with the sort of funding system in social care, where it's sort of like a crisis, cash injection, back to crisis, isn't giving anybody the opportunity to do some proper long-term planning. And that means that things like looking truly at strength-based approaches and personalised approaches end up being something that's sitting around the periphery because they don't have the time or the space to make that their main thing because they're too busy dealing with the crisis. And I think it goes back to a point that was made earlier, I think, by Gregory about the short-termism of what we're looking at. And I think that's personally one of the... It's a challenge of how our government's structured, in that most governments are thinking about the short term and the quick and easy wins, and actually it's going to take a really strong and positive leadership to make this impact in social care.
What time period are you looking at? Because the government would say they are bringing back multi-year settlements for local authorities when before it was sort of yearly. So they would say that they are giving a bit more certainty, but that's sort of 3 years. What kind of horizon are you looking at?
I'll be happier when they have rather than they say they will.
Well, fair enough.
but I mean, a 3-year settlement would be a good start. We're not there yet. That would be a good start. But it's really hard. And even for organisations like ourselves that are supporting the system, trying to manage your budget when you don't know, like we literally don't know what we've got in April. And local authorities are often in the same situation. So how do you make a long-term plan? And in fact, if we were to reform social care now, we would see some immediate differences now. Of course we would. But some of the differences that we would see, some of the benefits that Andrew was talking about, we wouldn't see for 10 years. And it needs a strong, determined government to put in place funding and reform for a system that is for the longer term benefit. And as has been mentioned, we've got there's a good majority there now that there isn't a reason why that shouldn't be done now, but we need to grasp that nettle and make it happen.
Thank you.
Thank you. Paulette Hamilton.
Oh, fantastic. I am going to give you a little bit of a rest, Andrew. So my question is based predominantly to Simon and Kathryn. The question for me is around the care market. Now, the preface to this is, I was a nurse for many years, had no idea about social care, went into local politics and became the cabinet member for adult health and social care in Birmingham. Massive system, and the problems within that system, within the care market, which really drove me mad, was the fact that we would give out packages of care. I was someone that really believed in direct payment, so empowering people to get their own services out there. But when they came and they had large packages of care, the problem we had was private organisations would a drop of a hat hand the whole lot back to us. We then had to pay double to literally get that care delivered by other partners because they saw the susceptibility in the market and they would take advantage of it. The question I've now got is, going forward, what could the future look like for the market if reforms are not forthcoming with some of the wicked issues that we've got going on at the moment? And it is only getting worse because of what you talked about earlier, the inaction that's currently happening and the things being pushed down the road. I'll start with Simon. Thank you.
I mean, it's a very, very topical question. So if you ask providers that question, they would say that there's a really serious risk of more of them going out of business or handing back contracts because of the extra cost burdens that have been imposed on them in the last sort of 6 months or so since the budget. And I think that's a really valid concern. If you look at the last 10 years, what you see is that the costs of providers have increased year on year because of the introduction of the minimum wage. So social care tends to pay staff at or around the minimum wage. The minimum wage has been increasing at more than inflation, and those costs have been passed on to providers. And for some, that's been extremely difficult to deal with. But actually what's happened generally is that the providers have been able to pass on those costs to local authorities, and local authorities have felt that they have to pay increased rates year on year in order to be able to ensure that they've got a market that can provide services. But what local authorities have done in turn is, because they've got a limited budget, they're reducing the number of people that they provide care to, so they ration care. So you've got this really unfortunate vicious circle whereby increasing costs are met ultimately by local authorities as much as they can, but that results in fewer people receiving services. And if we stack more costs onto providers without making sure that local authorities are funded sufficiently well to be able to pay them, then I think we've got a really serious problem that we're facing. So I think that's the most immediate issue. But you also see issues in that providers are able to command greater fees from self-funders than they can from local authorities. Now, there's a real injustice about that. If you're paying for your fees yourself and you're paying 40% more than the local authority is paying, so there's a real injustice. But it also creates a market dynamic which is unfortunate, which is that if I'm building a care home, I'm going to build a care home in an area which has a large number of self-funders because I can recoup fees more effectively there than in an area where there are very few self-funders. So you'll see that most of the majority of the care homes that are built in the last sort of 5 to 10 years tend to be built in areas with large numbers of self-funders. So it creates these imbalances in the market, which ultimately mean that a local authority in a more deprived area may struggle to attract companies to build care homes. So I think there's a range of issues, and they go back to this thing that if we're not able to pay a fair rate for the care that we provide, then we'll see the impact in terms of the local authorities having to pay enough but reducing the number of people that they support, and we'll also see imbalances in the market in terms of where services exist.
Fantastic. And Kathryn?
So yeah, I was going to say, 20 years ago I was an inspector. And we used to get people coming to the inspection, it was a predecessor to CQC, but we used to get people coming to us that had bought a big building and wanted to set up a care home because there was profit in it. It doesn't happen anymore. People don't do that now. I'm not saying nobody makes a profit in care. Of course they do, so don't keep doing it. But the people that make the profit generally tend to be the ones that are supporting self-funders. And actually, so we are seeing contracts handed back, and we are seeing the market retracting, and that's been over the last 20 years. And one of the issues with that is that is reducing people's choice and control as well. So if we look at home care, so not just care homes, if we look at home care, I can't remember where I saw this statistic, but there's been some work to show that to be able to provide good quality home care, they need to be charging £30 an hour. And a lot of local authorities are refusing to pay even more than what the minimum wage is. And actually, when people have got personal care and direct budgets, they can't afford to pay what the hourly rate is. So the amount of people that are available to provide home care or care homes to people that are not self-funders is becoming fewer and less choice out there for people. And in fact, even those that are, and this is what I will... for every single one of you, and I say this to myself, I've worked in social care since I was 13. I've been an inspector, I've been a care assistant, I've been a senior leader, I've been a commissioner, and I've been in the charity sector, okay? And what I thought was good quality care as a professional was turned on its head when I was looking for care for my granddad. So I went to look for care for my granddad, and I took him around, my auntie around the care homes that I'd been an inspector at. Wasn't good enough. Wouldn't put them in. Completely changed my mind. And I think actually we need to define what good quality care is first. What do we think is an acceptable standard of care for everybody? And going back to if we were to provide the right level of support and care for everybody, regardless of their location geographically and regardless of their means, what is that basic level of care that we're looking for? And I don't think we've got a universal view on that. I think I know what my view on it is now. But I think that is something that would need considering. And then are we funding the market enough to provide that? Because if we're not, and as has already been said, the majority of the care market is private. They might love the job, but they're not in it for love. They're in it to make any money. If they can't make any money, if it's costing them, they'll either give it back or they'll look at ways to save money, which might not be in the best interests of the person that they're providing for.
The challenge is, and then I'll hand back to the chair, should it remain in the private sector?
I think I've seen all of those innovations I've talked about were in the private sector. I think the private sector has got the ability to innovate. It absolutely has got the ability to innovate. But I think that isn't universal. And I think actually if we're going to talk about a national care service going forward, and what I mean by a national care service is what I've heard talked about in terms of a national set of standards, guidance, pay, etc., etc. We need to be very clear on what is the minimum level of care. And when I say minimum, it's probably maximum for some people that we're looking for. And the private sector needs to be incentivised to provide that. If we look at any other markets, if we look at anywhere else that is delivered by private sector, we don't expect them to do it and not make a living out of it. So I think we need to make sure that we're clear on what's to be provided and how it will be paid for.
I think that's a good place to stop. Chair, back over to you.
Thank you. Andrew George.
Thank you very much. Actually, the question I've been allocated, I think you can answer relatively quickly, so therefore I'd like to ask a supplementary on the back of what Joe was asking you, Andrew, about earlier. I think you've repeated this point twice, and I just wanted to find out how evidence-based it is, or whether it's based on reasonable assumption. And that is where you've said that if we improve health and social care and people live longer, then it will result in a larger social care bill because people will need more care towards the end of their life if they're living into their 90s rather than popping off in their 70s. What evidence base do you have you for that?
So it's not fantastic.
No.
Because data in social care, particularly life cycle data, is not good. But there was some evidence that we looked at 15 years ago when we did our work, and some that I've seen since then that suggests that's the case. Although, let me be clear, I'm not just talking about social care costs, critically pension costs as well. Yeah. So if we do social care better, people live. So I'm talking about the overall public finance costs.
Oh, right. That's a different matter, isn't it?
It is a different matter, but as far as government is concerned and the public the public finance costs, it's extremely germane and terribly important. Okay, so what I'm saying is, I don't think that I would start with my as trying to say the best argument for doing social care better is that we'll save money. I'm not sure that we will. The best argument for doing it is that we're not doing well at the moment, and we can give people more flourishing lives if we do. But I do also think that in the short run, if we do social care better, we will free up very significant NHS resources, because at the moment we are putting an enormous and unnecessary strain on the NHS.
Right. So in the cold hearts of the Treasury, they'll be looking at the pension budget and this, and perhaps making rather kind of potentially cold-hearted calculations on the back of that. I mean, it's just that I thought, and I wasn't sure whether, and I'm sorry to be vague about this, whether it was Professor Darcy or someone else who indicated that if you improve people's health and well-being into their 90s, then the social care and healthcare budget is less than if they fall ill in their 70s. But I'd like to see.
Medical officer who made that. It was the chief medical officer.
The chief medical officer. Maybe it was them. Maybe it was. Thank you very much. So it would be useful for us as part of the because it's very central to the question we're asking. On the question allocated, and I think it's kind of a fairly obvious answer. So therefore, I'll just give you a minute to answer it. Is simply that. The government has got its 3 shifts, all of which are very agreeable to everybody. I'm sure, moving people. One of which is the shift from hospital to community, and the question really is, to what extent is a failure to address the issues in adult social care going to impinge on the ability of the government to deliver that particular shift? I think the answer is obvious, but I thought I need to ask you.
I mean, it is fairly obvious, but it's also massively.
Yeah.
I mean, we have a massive number of people in hospital right now who don't need to be there, and there are 2 categories of that group. There are those who are in hospital for non-social care, not because of a social care failing, but because of something else, but who can't get out because there isn't social care available. And then there's probably a smaller group who are in hospital because of failings of social care and now still can't get out. It's a huge problem and a huge challenge for the government.
Okay. I mean, just supplementary on that, I mean, the figures that I've picked up in Cornwall alone indicate that actually of the delayed discharges within the acute sector over the last year, only 25% of them can be attributed to primarily, lack of social care packages. That actually others are a combination.
No, and that figure sounds right. I saw some figures in the last couple of days about Liverpool, where it looks like about a third. But we also need to distinguish between stocks and flows. So delayed discharges for social care are often lengthy, and if you have one elderly gentleman or lady in hospital for 20 days because there isn't any social care, that's probably at least 10 elective activities that are not possible. So no, I think a figure like 25% or 33% may be roughly, but that's still a large and not necessary figure.
Thank you. Jen Craft.
Thank you, Chair. Just following on from the hospital delayed discharge issue, one of the questions that kind of came up to me, I think it follows the discussion we've been having about how this is paid for and who pays, and often where the savings are realised, that's not the department that has to pay the upfront costs. Do you have any thoughts on models that can prevent readmission to hospital or delayed discharge, for example, virtual frailty wards? And whether or not that's necessarily a staff training issue in the social care sector, and if so, should that potentially be a cost borne by local ICBs or the health service, or if it's more about collaboration?
So I wouldn't claim to be expert on those particular questions, but I think it points to an absolutely central question. It's one that both Kathryn and Simon have already raised, which is the interaction between local authority budgets and NHS budgets. And I think one of the questions that it'd be really helpful for this committee to think about some more, and essential for Baroness Casey to address, will be this question of where budgetary responsibility lies. Social care is a local authority financial responsibility as a hangover from the fact that in 1948 it was the one bit of the welfare state that wasn't centralised. Got left with local authorities. At that time, it wasn't a very large activity. It's grown massively. Now, I think there are strong arguments for local variability in provision, because the way in which it makes sense to provide social care in the Highlands will be very different from the way in which it might make sense to provide it in the centre of a large metropolitan area. But the arguments for local finance of it, I mean, I think if we were starting from a clean sheet of paper, I can't think that we do that, and it leads to precisely the kinds of inequality, regional inequalities that Josh pointed to, that Kathryn talked about. It also leads to this kind of peculiar dance each year when the Treasurer will often say, well, we're proposing that the amount of funding available for social care will increase by X. But actually the amount of funding they're delivering for social care increases by X minus some significant amount, and the gap is to be met by changes in council tax. Whether we think that council tax was a sensible way of raising funding for social care if we were starting from scratch again, it's not at all clear that we would, and of course we need huge equalisation. So the distinction between the budgets of those who are financing and the budgets of those who are actually having to pay is critical, and I think is a huge obstacle to doing these things well.
Can I just say on, I can't speak to virtual wards, but in terms of preventing readmission, re-ablement and intermediate care services I think are incredibly important. And we talked about evidence earlier. There is actually pretty good evidence for re-ablement as an approach in terms of essentially getting people back on their feet, often quite literally, and actually regaining their independence, and actually therefore having a massive effect on their lives, but also preventing additional costs to the health service. But the last numbers I looked at with the National Audit of Intermediate Care a few years ago suggested we could do 2 or 3 times as much re-ablement and intermediate care as we currently do. There was that level of demand for it. So when we're talking about innovation, for example, and where should we be innovating, I think there's also a case of looking at the stuff that's actually working and actually spreading it more widely across the system, as well as looking for the pockets of new things that are coming up.
That was exactly my point.
Right, fine.
And sort of going a little bit wider than this, and on the kind of focus on collaboration and looking at who pays, I think, so Andrew, you touched on it a little bit about how perhaps local council tax and saying to people, you know, this is how you pay for your adult social care through the same way mechanism by which you pay for your bin collection is perhaps not necessarily how people would opt to do it. This is perhaps a wider, bigger question, but do you think that maybe a failure to grasp this in terms of from whether it's government, whether it's the wider general public, is there's something around general societal attitudes towards disability as a whole? Perhaps people don't want to or cannot imagine themselves becoming disabled, whereas everyone can imagine themselves needing to use the NHS probably at some point during a year, but people don't really want to cause that scope to imagine disability entering their lives. And perhaps there's that reluctance to really address this issue head on because it's not something that is seen as universal.
I think that's right, and it's part of the invisibility. And of course, you know, that's nuts. 80% of us are going to need social care, and need social care enough that we're going to pass the now extraordinarily tight local authority assessment test. So this is coming at almost all of us. You know, a very small portion of us will be walking up a hill and at the age of 93 in full health and whatever. But 80% of us are going to pass the local authority. So it is universal, but we don't like looking at it. Mm-hmm. And I think it's part of a wider set of issues about the invisibility of older people in general,
disabled,
but also of disability. Mm-hmm. So it's also critical to remember that half of what government spends in the UK is spent not on elderly care, but on working age adult social care, and then there's more on, and that's a group of the population that are very marginalised and not talked about. So I think facing up to these things is critical. But I think part of the reason that we don't face up to it, and part of the reason to go back to, I think it was Danny who raised the question of public education, I can't remember who, but is that we have a system that we're embarrassed by. So the reason that politicians on the whole don't talk about social care is because it's not, we don't have a system that we can be proud of. If we had a system that had a founding myth that we could be proud of, then we'd talk about it. And I think one of the critical reasons for reform is to create a structure that people are willing to talk about, because it's a structure that gives people some agency and some ability to control their own lives. So until we do that, I don't think we will find politicians and the media talking about it, because politicians won't want to talk about it because it's not something to be proud of, and the media won't want to talk about it because it's slightly terrifying. And social care at the moment is terrifying. It is. Shopping those prices, or it's like standing in the middle of the road with a lorry driving towards you, and the best you can hope for is you die before the lorry hits you. Well, that's not something that you're going to want to focus on. So if we can move to a structure where people have some agency, then maybe we'll get some more talking about it. But it is, we're not good at talking about it.
Is there a sort of almost a shift needed in attitudes towards disability? And I think about some of the framing around entitlement and sort of scrounger narratives that we see in some of the nastier parts of sort of discussion on this issue. And is there almost, it needs a shift from if some people receive care that they need to go about their lives, this isn't receiving something above and beyond what most people can expect.
I'm sure that's right. And I also think a shift in, so we need a shift in attitudes to those who need, and also recognition that, so self-reported life satisfaction amongst people receiving care is strikingly high, often higher than it is for the population as a whole. And this is not about being in some ghastly waiting room for the end. This is about people leading good, fruitful, flourishing lives. And we can help us all do that by facing up to it.
The House of Lords Committee used that very useful phrase, I think, which was evident to the committee, with someone with a disability saying, I'm wanting a gloriously ordinary life, simply wanting to be able to do the stuff that everybody else can do, when I want to do it and when I need to do it. And that seems to me, that I think is what we would all want if we had a disability or we need to rely on social care. We'd like to have that gloriously ordinary life.
Thank you very much. Back to you, Chair.
Thank you. Becky.
Thank you, Chair. So I'm going to, I suppose, end at the beginning, if you like. So I'm a public health consultant. So I hear a lot of what you're saying about being a Cinderella service, being invisible, not getting the funding that you need, needing to invest now for generational change in 10 years. So if I think about social care and prevention together, I think that there is a great opportunity that we do keep missing. So my specific question to you is, do you think social care reform could include a significant focus on a public health or a social care or a national care budget, whatever the relevant wording is, that budget for ageing well that builds capacity in older people and the care system alike? Do you think that's something that really we should push for?
Yes.
Great.
Would anyone like to expand?
Feel free to expand.
Can you expand to also include younger and disabled adults? I'm just going to give you another example. I compete at horse carriage driving, okay? And there's a young lady that competes with me, and she's tetraplegic. She's better than me as well, which is really annoying, but anyway. She had a car accident when she was 15, and she's now tetraplegic. And she has a personal budget and a very forward-thinking social worker that helps her to manage her personal budget in a way that suits her. She's managed to teach herself to do some of the most intimate care procedures with one hand, which I have to say I'm slightly worried about. She should have more care than she's got, but I'm sticking to the positives for this purpose. She uses her personal budget to pay for her carers to help her to compete in the horse riding. That's her passion. That's what her passion was before she had an accident, and she's kept that up. I've, apart from two examples I'm going to give you, I've not known her in hospital a single time I've known her. I've not known her have social services out. I've not known everything apart from two examples. So one of those examples is that her adapted car broke at the same time as the lift in her accommodation broke. She couldn't leave her bedroom for 6 weeks. And within that 6 weeks, she got pressure sores, she got depressed, she ended up having additional support workers out to her, and she ended up really down. She was on a really bad trajectory until these things were fixed and people managed to bring that out again. And just now, she's snowed in. She can't get out of the house because of the snow, and she's isolated, she's lonely. It's still early days, it's only been a couple of days, but I can see the same trajectory. And the reason I'm giving you this story is when we get social care right, when we get intervention right, and we support people to live their gloriously ordinary life, the fact that they are happier means that they're less susceptible to other things. Living well makes a huge difference to your ability to manage other things. And I'm aware that we're about to run out of time, and I just wanted to pick on something that was said earlier about the Chief Medical Officer's comment about getting ill at 70 or 90. I think the reason for the additional cost is because if you get long-term care needs at 70, you don't necessarily die at 70. You've got long-term care needs for 20 years.
Yes, exactly.
Whereas if you live well to 90, you might not need that care needs till you're 90.
Yeah, exactly. That's what he was implying, yeah.
And sorry, I know we're going to run out of time, but if I'm interested in what Simon said about the fact that social care, and perhaps Andrew and Kathryn said as well, doesn't set the world on fire. But you've done a lot of work, and social care is now being discussed more in this committee, sort of in the media, etc. But is there a case to be made that perhaps a national care service, which encompasses preventative care from myself, healthcare from, healthcare, and then social care, is a better way of looking at what we're trying to do, what Kathryn's talking about, which is that culture of care, the culture of change that allows Britain, the UK, the population to be proud of something? Is that something that the King's Fund has considered, looking at that sort of catch-all that says we're about caring regardless of where you are in this sort of health system?
Yeah, I think not just the King's Fund, that looking about health and social care as being two sides of the same basic coin, I think that's quite a widely adopted approach. But what doesn't happen is the money and the respect and the attention doesn't follow in the same way, and that will be a chance. So one of the potentials for this commission or any other commission is that it has the opportunity to bring some public attention and talk about health and social care in that context, I think.
Well, the bell suggests that we've reached the end of our session. I simply end by saying a massive thank you to all three of you for appearing today. It was incredibly rich and useful to us, and has set us, I think, on a very good path for the rest of our inquiry. So thank you very much. Yeah. Order.